this is Dr. Michelle Clayman, and this is a presentation on take-home naloxone. I work at a few different places. One, I work at a community opioid clinic called True North Medical, and then I also work at St. Mike's Hospital as an emergency physician and an addiction medicine consultant. I have nothing to disclose today. The learning objectives for today is to first understand the rates of opioid overdose in Canada, although I do have some American stats to show you. Second, to recognize the signs and symptoms of opioid overdose. 3, learn how to manage an opioid overdose. 4, how to understand the role of take-home naloxone. And finally, to identify resources for naloxone training of your clients. So you're all familiar with the faces on this slide. We have Prince and Philip Seymour Hoffman and a few others, and these are celebrities that we know have overdosed on opioids and have unfortunately died. However, we have to remember that opioid overdose just does not affect people who abuse opioids. Think about the 80-year-old grandmother who takes a few extra Percocets on a Wednesday because her back pain is flaring up, or a child who gets into his mother's methadone dose in the fridge and overdoses on opioids. So even though these pictures are representative of some famous people, we have to start thinking about others who might be at risk for opioid overdose. When we look at the statistics for...
Then she mentions all the signs of respiratory emergency, which mimic drug overdose, and then the good doctor, medical doctor, says give chest compressions. When you empower millions of people with what the doctor says is a life-saving technique, they're eagerly following orders, killing anyone with any breathing emergency.
There's a lot to cover. I'm sure you're thinking, how are we going to teach our patients or clients all these things in a very short period of time in the pharmacy? So you don't have to come up with these training materials on your own. Ontario will be coming up with some very shortly. I know the Ontario Pharmacy Association is working on the training materials. What we have right now to guide us is the training materials that have been used by Toronto Public Health. So this is an example of the card and poster that Toronto Public Health has been using for several years, and there is a slight modification to this, and I'll let you know as we go through each step. So first, they recommend that we shake and shout patients at the shoulder, shake patients at the shoulders and shout their name. So you want to see if the patient is responding. If the patient is not responding, 911 should be called immediately. 3, naloxone should be injected into the arm or leg muscle. Naloxone right now is available in vials and ampules. So if it is a vial, the top should be broken off. Often there is a safety top on the vial, and naloxone should be drawn out into the syringe and then injected intramuscularly. If it is an ampule, the plastic cap must be flicked off, and then the naloxone can be drawn out quite easily. The entire dose of the vial or ampule should be drawn up and then injected. 4th, Toronto Public Health recommends doing chest compressions. Again, as I mentioned this before, it is really hard to determine when somebody is not breathing well or gasping whether or not their heart is pumping. So chest compressions are essential in case they have had a cardiac arrest. Data does show that chest compressions are not going to harm patients if their heart is pumping, and again, can act as a form of deep stimulation and wake them up. Toronto Public Health has modified this step, and they have also added in rescue breathing if the bystander is appropriately trained in how to provide rescue breathing. It is an optional step, as we do know from studies that it is very difficult to teach and to learn how to give proper rescue breathings. So they focused here on chest compressions. Finally, step 5, you have to reassess the patient, see if the naloxone is working, see if the chest compressions are working, and if they are not and there's been no improvement, you can provide us a second dose of naloxone at 0.4 milligrams into the arm or leg muscle. After the second dose is complete, they recommend continuing with chest compressions until EMS arrives. Toronto Public Health has also produced this document outlining the signs of opioid overdose and recovery position. So they put some information here that helps remind patients what opioids are. So opioids include OxyContin, Oxy-Neo, fentanyl, heroin, Percocet, dilaudid codeine, morphine, and methadone. And again, naloxone only works for opioids. They've outlined the signs of opioid overdose, so can wake the person up. The breathing is very slow, erratic, or stopped. There's deep snoring or gurgling sounds. The fingernails or lips are blue or purple. Body is very limp, and pupils are very small. They then recommend a recovery position, so they've recommended putting the patient in the recovery position if they are unconscious and breathing, or if they have to leave the patient unattended. These documents are available free of charge on the Toronto Public Health website.
Read comment box for the medical information. Heart and Stroke Foundation CC'd Public Health and Dr. Laurie Morrison of Rescue in 2013 about their naloxone training, because chest compressions only is for sudden witness cardiac arrest for a person never trained only, and sudden witness cardiac arrest is a very rare event, and the signs are totally different than a breathing emergency. Unbelievable. She ceded to these people and co-author of Chest Compressions Only, which Dr. Clayman quoted. I put in a complaint into the College of Physicians and Surgeons about Michelle's training for the Ontario Pharmacists Association. They had a hearing for anyway, which didn't get too far. Meanwhile, I got the College of Physicians and Surgeons on tape saying we wouldn't teach that. Dr. Michelle Clayman's teaching we wouldn't do that. I know they wouldn't. Anyway, you guys have fun. Don't suffer any of the hundreds of causes of breathing emergency, because the signs can mimic drug overdose. Dr. Gordon Have phoned me years ago. He and his team are the world experts on chest compressions only. 20 years of his research down the tubes. He also sent me an email on the day that the 2015 AHA guidelines were published. This is unbelievable. You betcha it is. Because Dr. Have and any clinician knows what they're teaching is strictly verboten. Think, are breathing emergencies, or are they cardiac arrests? There's 10 million references in the medical literature says it's rescue breathing, and what they're teaching is dead wrong. Read the comment box and think before it costs you your life. Michelle Clayman was consultant for the Ontario Pharmacists Association. This is the Compendium of Pharmaceuticals and Specialties, the Canadian Pharmacists Association. Every pharmacist knows in an instant what she's teaching people to do is killing pharmacists or anyone that suffers any breathing emergency. Every pharmacist has 2 or 3 textbooks on poisoning drug overdose in their store. And it's respiratory failure. The ancients used to poison people all the time, and poisons or drugs didn't magically change their chemical structure. They still cause death. Respiratory failure. Stop breathing. You stop breathing, you don't come alive until someone starts breathing for you. Unbelievable. This is your tax dollar going around teaching millions of people murder. And they're really doing it because the doctors told them to. They don't believe the doctors are mass murderers. Anyway, it's a no-brainer. I knew it at 5 years old. A breathing emergency is a breathing emergency. You don't have naloxone, keep them alive with rescue breathing. Unbelievable. You're being mass murdered and they're using your tax dollars to do it. Read the comment box and then think.